Welcome back. This week, our readings push us to rethink how power, addiction, and communication shape the counseling process. We'll focus on three themes: power and agency in recovery, redefining addiction, and the flow of conversation in counseling. Now, I want to pause right at the start and invite you to really lean into this week. If you're like most people coming into the counseling field, you've already absorbed a lot of ideas about what addiction is and what recovery should look like. Maybe you've heard that people with substance use disorders are powerless. Maybe you've heard that recovery only counts if it's abstinence. Maybe you've seen professionals rely on confrontation more than collaboration. But here's the call to action. These assumptions don't always hold up in practice, and they can limit our ability to connect with and support clients. The work we're doing this week is about challenging those assumptions and opening up new possibilities. We're asking, what does it look like when recovery is centered on empowerment rather than powerlessness? How do we define addiction in ways that expand and not narrow our understanding of people's lives? And what happens when our conversations with clients flow rather than push or pull? So that's where our readings come in. Maia Szalavitz in Undoing Drugs and William Miller and Stephen Rollnick in Motivational Interviewing are both pushing us towards the more humane, client-centered approaches to treatment. In this module, we're going to dig into some of the core debates and ideas shaping how we think about addiction and recovery. So here's where we're headed today. We're going to start with the 12-step model and the concept of powerlessness. Since this has been the dominant approach for nearly a century, it's important that we understand its history, meaning, and impact. And then we're going to look at the flip side, how the same language of powerlessness can land very differently for others, sometimes leading to shame, alienation, or a sense of failure. From there, we'll move into Szalavitz's perspective, which reframes recovery as an act of empowerment, finding power in connection, competence, and autonomy. We'll also connect this to motivational interviewing, which puts client autonomy at the center and helps us practice counseling as a flowing, collaborative conversation rather than a confrontational one. And along the way, we'll explore practical tools that you can use: stages of change, harm reduction, medication-assisted treatment, OARS skills, ASAM criteria, SBIRT, and more. And finally, we're going to wrap up with some reflection: how these perspectives might challenge or expand the way that you approach assessment, treatment planning, and everyday conversations with clients. So that's our roadmap. Remember, you don't have to leave here today with all the answers. My hope is that you just leave with more curiosity, a few new tools, and maybe even a different lens for thinking about what recovery can mean for different people. So before we get into Szalavitz's argument, we need to set the stage by talking about the 12-step model, because that's the backdrop that she's responding to. The 12-step approach began with Alcoholics Anonymous, or AA, in the 1930s and later spread to countless other fellowships. There's Narcotics Anonymous, Gamblers Anonymous, Overeaters Anonymous, Sex Addicts Anonymous, Codependents Anonymous, and many more. And the word alcohol in AA Step 1 is interchangeable with whatever the addiction is: alcohol, drugs, gambling, food, sex, relationships, spending, codependency, social media, whatever. The framework is designed to apply across different behaviors, which is why today there are over hundreds of 12-step offshoots. At the heart of every fellowship is Step 1, which says, we admitted we were powerless over, fill in the blank, that our lives had become unmanageable. This is the entry point. Step 1 represents surrender to the disease model of addiction, which sees addiction not as a moral failing, but as a chronic, relapsing illness that cannot be managed through willpower alone. The logic is, if you could control your use, you wouldn't be here. Step 1 is about dropping the illusion of control. And for many people, this admission is life-changing. It can be a relief to stop fighting and to name what feels true. I can't beat this alone. For someone who has spent years in chaos, burning bridges, and losing battles with themselves, hearing others admit powerlessness can lift the crushing weight of shame. It says, you're not weak, you're sick, and there's a path. For many, Step 1 opens the door to hope, fellowship, accountability, and the possibility of healing. Powerlessness, in this sense, isn't total helplessness. As AA literature and the Serenity Prayer emphasize, it's about admitting that there are things that you can't change, like your addictive relationship to substances, so that you can focus your energy on the things you can change, like showing up to meetings, working with a sponsor, practicing honesty, and seeking support. Another way people in AA often describe this is through the allergy analogy. The idea is that people with an addiction have an abnormal reaction to alcohol or drugs. If you had a peanut allergy, you would be powerless over peanuts. Eating them would set off a chain of physical reactions beyond your control. You wouldn't say, oh, I'll just use willpower and I'll make the allergy go away. You'd know that peanuts aren't safe for you, and that you'd need to take precautions to avoid them. Now, imagine if peanuts were central to your life. If your job was working in the peanut butter factory, your life would quickly become unmanageable. You'd be sick constantly, maybe hospitalized, you'd miss work, lose your paycheck, fall behind on bills, and eventually lose opportunities to enjoy social events, friends, and family. The peanut itself is really small, but the ripple effect of exposure would overwhelm your life. And that's how AA frames addiction, not as a weakness, but like having an allergy to alcohol or drugs. Once those substances are in your system, the body responds differently than it does for people without the allergy. You can't will it away. You can only accept that relationship for what it is and then build a life around avoiding the thing that harms you. This allergy idea ties directly back to the disease model of addiction. Just as diabetes changes the way the body processes sugar, or asthma changes the way the lungs respond to triggers, addiction changes the way that the brain and the body respond to substances. The disease model says this isn't about bad morals or lack of discipline, it's about a chronic health condition that alters physiology. In this way, step one's admission of powerlessness is less about character and more about accepting the medical reality of a condition you cannot simply outthink or outmuscle. In fact, many members describe step one as paradoxical. Surrendering to powerlessness is what gives them new strength. AA materials and worksheets often break step one into three ideas. The first being powerlessness over the amount used. Once you start, you can't stop or control intake. A common 12-step phrase you might hear is, one is too many, a thousand's never enough. And then there's powerlessness over consequences. No matter how you try to manage the fallout, bad results are going to happen anyway. And third is unmanageability, the chaos, broken relationships, health problems, and spiritual emptiness that make life unbearable. So why are we spending time here? Because powerlessness has been the cornerstone of recovery language in the United States for nearly a century. Many of your clients will have been exposed to it. Some will swear it saved their life, while others will carry wounds from it. To understand today's debates about empowerment in recovery, we have to understand that starting point. But there's also a flip side. The language of powerlessness doesn't land the same way for everyone. For some, instead of relief, it feels stigmatizing or disempowering. It can reinforce the idea that people with substance use disorders are fundamentally broken, incapable, or forever dependent on a group or higher power. And because 12-step programs often emphasize lifelong abstinence and ongoing participation, the model can create a sense that recovery must look one way only. This paradox is important. For one person, admitting powerlessness is the first breath of freedom. For another, it feels like erasure of dignity. Both experiences are real, and as counselors, we need to hold that tension without judgment. The dominance of the 12-step model means that clients often come into counseling with these ideas already in their heads, or with wounds from feeling like they failed at 12-step. Some may carry a sense of shame for not getting it, while others may feel anger at being told their only option was a path that didn't fit their beliefs or experiences. For example, clients who are deeply secular may struggle with higher power language, and trauma survivors may find the emphasis on surrender triggering rather than healing. And this is where Maia Szalavitz comes in. She isn't dismissing the 12-step model or denying its value. She acknowledges that it's helped millions, but she asks a harder question. What about the people it hasn't helped? What about those who leave meetings feeling shamed, alienated, or disconnected because they don't resonate with the idea of powerlessness? Szalavitz reframes recovery not as surrender, but as empowerment. In her view, recovery is about finding power, power in connection, in competence, and in autonomy. Instead of asking people to admit what they can't do, she asks them to notice what they can. Rather than starting with brokenness, she says potential. This perspective resonates strongly with motivational interviewing. Miller and Rollnick remind us that change is more likely when people feel like they're in control of their choices. Autonomy isn't just a nice bonus, it's central. Clients lean in when they sense their freedom is respected, and they pull back when they feel controlled. When we shift the focus to power and agency, the counselor's role also shifts from being an authority who diagnoses problems to being a collaborator who helps clients identify and build on their strengths. So if recovery is about finding power and agency, then one of the most practical ways that we see that come to life is through the idea of recovery capital. This phrase has become a bit of a buzzword in the field, but it has a really deep meaning. Recovery capital refers to the internal and external resources people can draw on to initiate and sustain recovery. This term was developed by William Cloud and Robert Granfield in the late 1990s. They wanted to shift focus away from pathology towards strengths. Recovery capital includes things like social capital, which can be supportive friends, family, community, or peer networks. There's physical capital, and that would be basic needs like housing, transportation, financial stability. There's human capital that can be like education, coping skills, job skills, self esteem. And then there's cultural capital, like values, beliefs, and traditions that give life meaning. And if this sounds familiar to you, you might want to go back and revisit Maslow's hierarchy of needs. I always feel like there's a lot of overlapping pieces between these two. But when we talk about empowering clients, we're often talking about helping them recognize and build recovery capital. Someone may not be ready to stop using, or maybe they want to reconnect with their kids. That relationship is recovery capital. Or maybe somebody has a stable job that they don't want to lose. That's recovery capital too. These resources can become leverage points for motivation and change. Now, let's think about how this plays out with clients who are court referred. Many people enter treatment not because they want to, but because they've been ordered to by a judge. These clients often arrive in a state of ambivalence, stuck between a rock and a hard place. On one side, they feel forced into treatment, and on the other, they're staring down the possibility of jail time or legal consequences. So it's easy to fall into a trap of trying to make them change. But here's the truth: they do still have choices. They can choose whether or not to engage. They can choose whether or not to see treatment as an opportunity or just wait out the clock. They can even choose consciously that jail feels like a better option than treatment, and that's still a choice. Our job is not to force anybody into recovery. Our job is to help clients make informed decisions about their lives. That means giving them space to weigh their options, to think through what matters most to them, and to recognize the consequences of different paths. Sometimes that means that they'll decide treatment isn't for them right now. And as much as that might be hard for us to sit with, it's still their decision. And this is where the moral model and the biopsychosocial model collide. The legal system often operates on consequences and punishment, while our model is about understanding and supporting human behavior and context. When these worlds overlap, we can feel pressured to become enforcers. But motivational interviewing and Szalavitz reminds us that we're not here to enforce, we're here to invite. When we affirm autonomy, even in court-referred situations, we actually create more room for change. A client who feels respected in their ability to decide may be more likely to engage than one who feels cornered. So here's your first pause and reflect question of this lecture. How do you reconcile Szalavitz's critique of powerlessness with motivational interviewing's focus on autonomy? What does it mean for a client to have power in their own change process? So you can pause here, take some time, think about it. I really am curious to hear your answers. Maia makes a powerful argument in Undoing Addiction. She says addiction is best understood as a learning disorder rather than a moral failing. So that's another shift away from that allergy analogy too. For a long time, society has treated addiction as a problem of character, something that happens because people are weak, selfish, or irresponsible. But neuroscience and psychology give us a very different picture. Addiction isn't about bad morals. It's about learned patterns of behavior that become reinforced in the brain. Substances teach the brain to expect rewards, and over time, these pathways get strengthened while other pathways, like the ones for healthy coping or long-term decision-making, get weakened. The result is a cycle where the brain keeps learning to seek the substance, even when the person consciously wants to stop. When we understand addiction this way, it changes how we respond as counselors. Instead of focusing on punishment or shame, we focus on healing, unlearning, and relearning. We look at not only intoxication and withdrawal symptoms, but also at the broader neurological, psychological, and social dimensions of a client's life. And most importantly, we expand the range of recovery options beyond abstinence alone. So let's break this down into 3 practical pathways that build on Szalavitz's perspective: harm reduction, medication-assisted treatment, and stage of change matching. Harm reduction is often misunderstood as giving up on recovery, but that's not what it is at all. Harm reduction is about meeting people where they are and recognizing that any positive change matters. It acknowledges that while abstinence may be the safest long-term goal for some, it isn't realistic or even desirable for everyone at every stage. Think of it this way. If someone is injecting drugs multiple times a day and they move to using fewer times or switch to a safer method like intranasal instead of injection, that's harm reduction. That single shift reduces multiple risks. It lowers the chance of contracting bloodborne illnesses like HIV or hepatitis C. It decreases the risk of skin infections or abscesses, and lessens the danger of collapsed veins and other long-term injection-related damage. Reducing frequency also lowers overdose risk and gives the body more time to recover between exposures. Harm reduction can also look like carrying around and using Narcan or naloxone to reverse overdoses and not using alone, or testing substances for fentanyl or other drug contamination. Each of these steps may not stop use entirely, but they reduce the likelihood of death or even severe injury. With alcohol, harm reduction might mean drinking less often, pacing drinks with water, or making the choice not to drive after drinking. These decisions reduce risks of accidents, injuries, and long-term organ damage. Even small changes like choosing a safer setting to use in, ensuring sterile supplies are available, or setting personal limits around substance use can meaningfully reduce harm. These steps may seem minor, but they add up to real protections against injury, illness, and loss of life. The point isn't perfection, it's progress. In fact, the phrase progress, not perfection, which comes from the 12-step tradition, captures this spirit well. Harm reduction honors the idea that people don't have to make every change all at once. Instead, they can take gradual steps that preserve dignity, protect health, and keep the door open for future growth. When we frame recovery this way, we're not measuring success by whether someone has reached abstinence. We're measuring it by whether they are safer, healthier, and more empowered today than they were yesterday. Another pathway is medication-assisted treatment, often called MAT. These are FDA-approved medications to help people manage cravings, withdrawal, and relapse risk. So let's look at some of the most common ones. There's methadone, a long-acting opioid agonist taken orally, usually as a liquid. It prevents withdrawal and reduces cravings, but isn't meant to produce the same high. So think of the brain receptor site as a lock. Methadone is a key that fits in perfectly and fully turns the lock, opening the door all the way. The downsides of this can include the requirement for daily visits to a methadone clinic for observed dosing, and that can be really burdensome on clients. Another medication is buprenorphine, and that goes by brand names you might have heard as Subutex or Suboxone, Zubsolv. There's also long-acting injectables like Sublocade or Brixadi. This is a partial opioid agonist. What that means is that it attaches to the same opioid receptors in the brain as drugs like heroin or oxycodone or even that methadone that we just talked about, but it doesn't fully activate the receptor site. Because of that, it reduces cravings and withdrawal symptoms without producing the same level of euphoria. An analogy here is that buprenorphine is like a key that only turns the lock halfway. The door opens just enough to relieve withdrawal and cravings, but not enough to swing wide open. And one of the key advantages of buprenorphine is the flexibility. There's sublingual forms taken as tablets or films under the tongue, and they can be prescribed in office-based settings so that clients don't have to go to a methadone clinic every day. This can really reduce stigma and make treatment more accessible, especially for people balancing jobs, childcare, or other responsibilities. And the injectable formulations like Sublocade and Brixadi last about a month in the body. For clients who struggle with daily adherence, or for those at higher risk of overdose, these long-acting options can be life-changing. They might help stabilize the brain over time, reduce the daily decision-making around dosing, and lower overdose risk by blocking stronger opioids from binding fully to the receptor site. And of course, there are downsides. Some clients dislike the feeling of being locked in with the monthly injections or may experience injection site discomfort. With the sublingual films, diversion or misuse is still possible, though the addition of naloxone in the Suboxone helps to reduce that risk. And like all medications, buprenorphine requires consistent monitoring and a supportive treatment environment to be most effective. Still, the evidence is strong. Buprenorphine improves retention in treatment, reduces overdose deaths, and helps people build stability in their lives. For many clients, it offers a middle ground, relief from the chaos of withdrawal without daily clinic visits that methadone requires. And the third one I want to talk about is naltrexone, and it goes by the brand name of Vivitrol when given as a month-long injection or Revia in pill form. It's an opioid antagonist, so that just means that it blocks the effects of opioids altogether. It doesn't stop cravings, but it removes the reward if somebody does use. It can be used for alcohol use disorder to reduce heavy drinking, and it can also be used for opioid use disorder. So if we're looking at that lock and key analogy, naltrexone is like shoving a beach ball into the lock. No other key can fit, and the door can't open at all. And all of these medications work in different ways. Some by filling the opioid receptor to prevent withdrawal, others by blocking the receptor entirely. But the shared goal is to stabilize the brain and to give people a fair shot at recovery. MAT is not without stigma. Some people see it as replacing one drug with another, but the evidence is clear. MAT saves lives, reduces relapse, and increases engagement in treatment. Now, the third pathway that I want to talk about is about matching interventions to a person's readiness for change. This idea comes from Prochaska and DiClemente's stages of change model, which gives us a framework for understanding how people move through recovery, not in a straight line, but in a cycle of progress, pause, and often recycling. And I know I put a straight line on this slide. It just makes sense to my brain to make a slide that looks like this, but it also might be a good idea for you to map out what stages of change might look like to you. not a straight line, not necessarily linear. Some people draw it in kind of like a spirally squiggle that moves up or moves down. What does it look like to you? But anyway, you've probably heard the phrase, meet the client where they're at. It's a buzzword in counseling, but what does it actually mean in practice? Too often it gets thrown around without context. The stages of change give us a concrete way to live that phrase out. They help us identify where the client is in their process and tailor our interventions accordingly, rather than relying on assumptions about recovery should look like. So the stages are pre-contemplation. The person doesn't see their use as a problem. So the counselor action for pre-contemplation would be to avoid lecturing or prescribing solutions. Instead, focus on building rapport and gently raising awareness. Motivational interviewing strategies like reflective listening, affirmations, and exploring discrepancies between values and behavior can help plant seeds of insight. The second one is contemplation. So in this stage, they're starting to see the downsides and may feel ambivalent about change. Here, we want to normalize ambivalence and help the client explore both sides, the perceived benefits of use and the costs of use. The goal here is not to push for change, but to deepen reflection and tip the decisional balance towards action when the client's ready. The third stage is preparation, and this is where they're planning to make a change. Here, we want to help clients identify small, realistic first steps. This could include setting a quit date, practicing refusal skills, or exploring treatment options. The counselor's role is to support planning and build confidence, while also anticipating barriers and transforming stages to overcome them. The fourth stage is action, and this is when they're actively changing their behavior. Here, we want to provide skills and training and support for behavior change. This might include relapse prevention strategies, coping skills, and connecting the client to social supports or mutual aid groups. Here, the counselor is a coach, offering encouragement, problem solving, and accountability. The fifth stage is maintenance. They're working to sustain changes. We want to reinforce progress and help clients integrate new habits into their daily life, explore potential high-risk situations, strengthen recovery capital, and revisit coping plans. The focus is on stability, resilience, and long-term growth. And then there's another stage in here that clients don't necessarily ever have to get to, but if they do, it's part of the cycle. So we would call it either relapse or recycle. I've also seen it called reoccurrence. And this is just returning to old patterns, often looping back into earlier stages. Here, we want to avoid framing relapse as failure. Instead, see it as part of the learning process. Work with the client to debrief on what happened, identify triggers, and adjust strategies for the next cycle. Re-entry into treatment should be framed as resilience, not defeat. And this is where the concept of resistance in counseling, especially in motivational interviewing, needs to be reframed. Resistance is often interpreted as a client being unwilling, unmotivated, or maybe even non-compliant. But more often, resistance is actually a mismatch between the client's stage of change and the counselor's interventions. If a client is in pre-contemplation and is being pushed towards action steps, of course they're going to push back. This doesn't mean they're resistant. It means the counselor isn't meeting them where they are. When we see resistance through this lens, it stops being a failing of the client and instead becomes feedback for us as clinicians. It's an invitation to pause, reassess, and adjust our approach so that we're truly aligned with the client's readiness. And this ties directly to Szalavitz's point about addiction as a learning disorder. People don't just simply flip a switch into recovery. They learn and they relearn through experimenting, practicing, and sometimes failing forward. Our interventions must respect that process, supporting growth at each step rather than demanding immediate transformation. So there's two tools worth introducing here that help us put these ideas into practice. There's ASAM criteria and there's SBIRT. So the ASAM criteria is developed by the American Society of Addiction Medicine. That's what ASAM stands for. It's one of the most widely used frameworks in the United States for determining appropriate treatment placement. Instead of only looking at drug use itself or even a diagnosis, ASAM uses a multidimensional biopsychosocial assessment, and it looks across 6 dimensions: acute intoxication and or withdrawal potential, biomedical conditions and complications, emotional, behavioral, or cognitive conditions and complications, readiness to change, relapse, continued use, or continued problem potential, and the 6th dimension is recovery or living environment. This comprehensive assessment helps us understand not just what the person is using, but the full context of their risks, resources, and needs. And importantly, ASAM is used at every level of care in addictions treatment. And levels of care typically include something like early intervention, which would be considered level 0.5, education or prevention services for people at risk, but not yet meeting criteria for a substance use disorder. So oftentimes you'll see this happening in high schools, or with adolescents. There's a lot of early intervention work happening there. Then we move on to outpatient services, AKA level 1. And this would be weekly or less frequent counseling sessions focusing on the substance use. Level 2 is intensive outpatient or even partial hospitalization. This is more structured programming, often several days per week. Level 3s are residential or inpatient services. This would be 24-hour structured treatment and living environments. And then there's a level 4, which is medically managed intensive inpatient treatment or residential treatment. This is considered hospital level care for people with severe biomedical or psychiatric complications. So to meet criteria for level 4, the client would have to be showing a lot of needs in the ASAM dimensions of 1, 2, 3, 5, and 6. And ASAM just helps us justify which level of care is most appropriate by matching the intervention with the client's needs. For example, somebody with severe withdrawal risk might need a medically managed detox, while somebody with stable health but ongoing cravings might do well in outpatient counseling with MAT support. Without ASAM, placement decisions can become arbitrary or even inconsistent. With ASAM, they're structured, evidence-based, and defensible. And if you end up working in a substance use treatment center, you are going to learn so much more about the ASAM criteria because ultimately it's also the way that we communicate with clients' insurance companies to justify placement in a level of care at any given time. Now, the second tool we call SBIRT, and it stands for screening, brief intervention, and referral to treatment. And this is a public health approach that's often used in primary care clinics, emergency rooms, or other general health settings. So screening involves a quick questionnaire to identify risky or harmful substance use before it escalates. Really common screening here would be like the CAGE questions. CAGE, C-A-G-E, the C stands for cut down. Have you ever felt like you should cut down on your drinking or drug use? A would be annoyed by criticism. Have people annoyed you by criticizing your drinking or drug use? G, guilty feeling. Have you ever felt bad or guilty about your drinking or drug use? And E stands for eye opener. Have you ever had a drink or used drugs first thing in the morning to steady your nerves or get rid of a hangover? So that's the screening part of it. There's a lot of other ways to do a screening, but I think the CAGE is really easy and simple because it's only 4 questions and they're pretty easy to remember. And there's just yes or no answers too. So the idea here is that 2 or more yes answers might suggest a higher likelihood of a problem. Then what comes next is a brief intervention. So that's a short motivational conversation, usually 5 to 15 minutes, that raises awareness and encourages the person to consider change. So again, we want to look at, okay, maybe this is the first time somebody's even considering this. So they're likely in pre-contemplation or contemplation. So we want to use this brief intervention skill that focuses a lot on those needs. And then the last part is referral to treatment. And that happens if the screening and brief intervention show the person needs a higher level of care, such as outpatient counseling or residential treatment, something that they couldn't just handle within their PCP's office. So what makes SBIRT powerful is that it catches people early, sometimes even before they meet full criteria for a substance use disorder. It provides a gateway to care while still giving clients choices about their steps. Both ASAM and SBIRT remind us that addiction treatment isn't just about reacting to a crisis. These tools create structured, evidence-based pathways that help us match the right intervention to the right person at the right time. They also support autonomy. Clients are given options, education, and guidance, not forced into a one-size-fits-all approach. And here's our second pause and reflect section here. So how does Szalavitz's reframing of addiction compare to your prior understanding? And how might this shift the way that you approach assessment or treatment planning? Miller and Rollnick describe motivational interviewing not as a checklist of techniques, but as a flowing conversation. And those are the words they actually use, flowing conversation. How lovely, right? So in this, it's less about applying tricks and more about adopting a stance of curiosity, compassion, and respect. When counselors approach conversations with reflective listening, affirmations, and openness, they create conditions where clients feel empowered rather than controlled. And this style matters because it directly supports some of the most challenging clinical situations. For example, it can build rapport with clients experiencing withdrawal or relapse when shame and fear are high. It can reduce pushback with mandated clients who often feel coerced and defensive. And it can help clients articulate their own reasons for change, reinforcing autonomy and agency. So let's look at 3 core tools that are going to help us create that sense of flow. We're going to look at OARS skills, change talk versus sustain talk, and how we understand resistance, which we already kind of touched on a little bit, but we're going to go more in depth. So the acronym OARS gives us a practical way to remember the building blocks of motivational interviewing. O stands for open questions. Instead of yes or no answer questions, open questions invite exploration. For example, What worries you most about your drinking? That question's going to open space in a way that, do you think your drinking is a problem? Doesn't. A stands for affirmations. These highlight client strengths, efforts, or values. So, for instance, it sounds like you really care about being there for your kids. That statement affirms a motivation that they already hold. R stands for reflections. Reflective listening is the backbone of motivational interviewing. It means not only repeating what the client says, but also capturing the underlying meaning. If a client says, I can't get through a day without pills, a reflection might be, it sounds like using feels like the only way to cope right now. And then finally, S stands for summaries. Summaries pull together key pieces of what a client has said, showing that you've been listening and helping them hear their own motivations and concerns more clearly. Used together, OR's skills keeps the conversation flowing, collaborative, and respectful. Miller and Rollnick also make the point of they want to look at ratios so that it's not all open questions, right? When we ask too many open questions in a row, it can feel like an interrogation, which is not what we want to do. And often we'll put clients on the defensive. If you can use a 2-to-1 ratio of using affirmations, reflections, and summaries, 2 of those to 1 open question, that's the sweet spot that they're looking for. Now, when we're looking at change talk versus sustained talk, we want to learn to hear the difference between the two. Change talk is when the clients give us their own reasons, desires, or intentions for change. These are the moments to listen for and highlight. So examples of this might sound like, I don't like how much I'm drinking. My daughter deserves better than this. I know I could do this if I really tried. Or I felt so much better the last time I cut back. When you hear change talk, your job isn't to rush in with advice or say, great, let's make a plan right now. Instead, you reflect back, maybe even amplify it so that the client can hear their own motivation out loud. So that's a place where affirmations, reflections, or summaries might really help. Now, sustained talk, on the other hand, is when the client voices the reasons to stay the same. This might sound like, well, I need it to sleep. I can't sleep without it. Everyone drinks like this. It's normal. Or, not that bad. I can handle it. Or maybe even, well, I've tried quitting before and it never works. So this is where counselors sometimes get tripped up. It's tempting to correct, confront, or debate the client when you hear sustained talk, especially when it sounds like denial. But in motivational interviewing, we don't treat sustained talk as resistance. It's ambivalence being voiced. It's a sign the client is still weighing the pros and cons, and our role is to explore that, not shut it down. So here's what it isn't. It isn't ignoring sustained talk or pretending like you didn't hear it. It isn't arguing or saying, yes, it is, that's bad. It isn't jumping straight into problem solving. What it is reflecting back what you hear without judgment. So for example, if a client says, I need it to sleep, you might respond, right now, drinking feels like the only way that you can get rest. You might gently ask some questions to open space for ambivalence, like, well, what do you notice about how you feel the next day when you use it to sleep? And you also might want to try highlighting and reinforcing change talk whenever it does show up, even in small ways. Over time, the more clients hear themselves arguing for change, the stronger their own motivation grows. Our role isn't to convince them, it's to create the conditions where they can convince themselves. Now, let's talk about the word resistance. This word has a lot of baggage in counseling. It often implies that the client is the problem, that they're unwilling, unmotivated, or just being difficult. But in motivational interviewing, resistance is reframed not as a client trait, but as a signal. It often means that the counselor is out of sync with the client's stage of change. And if this sounds familiar, it should, because I just talked about it. So let's just refresh a little bit. Think back to that phrase that we discussed earlier, meet the client where they're at. Resistance is what we see when we don't do that. If somebody's in pre-contemplation and we start prescribing action steps, they will push back. If somebody's already in action and we keep circling around awareness raising, they'll feel stalled and frustrated. What looks like resistance is usually just a mismatch between where the client is and what we're offering. So what does resistance look like in practice? Passive resistance might look like missed appointments, silence in session, vague answers, or nodding politely without any follow through afterward. It's subtle, but it often signals ambivalence, fear, or even paralysis in the face of change. Now, active resistance is a little easier to spot. It might sound like arguing, dismissing suggestions, directly rejecting treatment goals, or even escalating into conflict. Often, this is a fight or flight response to feeling pushed too hard, too fast, or into a direction that the client didn't choose. And here's an important truth. As counselors, we can accidentally create resistance. It happens when our expectations don't line up with the client's readiness. For example, if we assume a court referred client should be motivated simply because they're in treatment, we're likely to push too quickly. If we expect abstinence when a client is just starting to think about cutting back, we might hear them shut down or push back. This is why resistance is actually useful information. It's not failure, it's feedback. It tells us to pause, check ourselves, and recalibrate. Instead of asking, why isn't this client motivated? We can ask, how am I showing up in a way that might be out of sync with their stage of change? In other words, resistance isn't a sign of client weakness. It's a mirror that reflects our own approach back to us. If we can shift how we see it, if we can treat resistance as communication rather than defiance, it becomes an ally in the process. Imagine that. It helps us to notice when our expectations might be ahead of the client's reality, and it nudges us to slow down, meet them in their ambivalence, and let their motivation grow at its own pace. So, one of the ways we can practice this is through role plays. For example, you can practice responding to sustained talk without arguing or navigating a scenario where a client pushes back against a court mandate. Role plays are going to help us develop the skill of staying curious, affirming autonomy, and letting the conversation flow rather than get caught in power struggle. So let's just do a little practical vignette here. Imagine that you're meeting with James, a 32-year-old client who's been referred to treatment by the court after a second DUI. He tells you, I don't really think I need to be here. Yeah, I drink, but everybody I know drinks, and it's just bad luck that I got caught twice. I'm not an alcoholic. I've got a job. I pay my bills. I show up for work every day. The whole thing is just overblown. When you ask him to walk you through his drinking patterns, he admits to drinking most nights, often 5 or 6 beers, sometimes more on weekends. He's had some arguments with his partner about it, but brushes that off, saying, she nags about everything. He has no medical issues at the moment, and he's never experienced any withdrawal symptoms. During the session, he leans back in his chair with his arms crossed, answers questions briefly, and occasionally smirks when you mention treatment goals. He says, I'll do whatever I have to do to get the court off my back, but don't expect me to quit drinking. So let's think about James together. The first question that I have for you is, what stage of change would you say that James is in? And you can pause here if you want a second to think about it before I start telling you what I think the answer is. But at first glance, to me, it sounds like he's in pre-contemplation. He doesn't see his drinking as a problem, he minimizes the consequences, and he's only in treatment because the court told him to be. But you might also make the case that he could be closer to contemplation because he admits that his partner has some concerns and he acknowledges to drinking most nights. That tiny crack of awareness could be an opening. And here's where bias comes in. We might look at his pattern of 5 to 6 beers a night and decide that he needs to be in preparation or action. But that's us imposing what we see, not where he's actually at. It's important to name the tendency and to check ourselves. Now, the next question, based on what you know about ASAM levels of care, which again might not be more than what I just told you, what level of care might be appropriate for him and why? And maybe you want to go back and review that slide just for more information, or do a quick Google search just to see a little bit more about ASAM levels if you're not already familiar with them. What it seems like to me is that James is medically stable, he doesn't report withdrawal symptoms, and he's working full time. So he wouldn't necessarily need maybe a detox or even hospitalization. And that working full time, we could count that as recovery capital. So that might not be something that we would necessarily want to interrupt with an inpatient treatment stay. So that would likely place him in either level 1 outpatient services, so weekly counseling sessions, or some might even argue for level 2 intensive outpatient, especially since he has 2 DUIs and is court mandated. And that could provide more structure and accountability for him. Again, there isn't one correct answer here. It's about matching his needs, his risks, and environment with the most appropriate level of care, not just what the legal system or our own bias might want to push. He's also got to agree to it too. So if we say, hey, you really might benefit from intensive outpatient, and that's where we're going to meet 3 times a week for 3 hours a group, and we're going to talk about coping skills and relapse prevention and just, building a foundation for recovery, he might say, yeah, no, I'm not going to do that. In that case, we want to meet him with the least restrictive level of care. And we say, okay, well, if you don't want to do that, what about once a week? And he might actually agree to that. My next question for you is, how might resistance be showing up in this session? Passively, actively, or both? Now, I would say both. He crossed his arms, he's giving brief answers, and his smirks are maybe some examples of passive resistance. It's that subtle disengagement. But when he says, don't expect me to quit drinking, we could consider that active resistance. That's a direct pushback. And the key here is not to see him as being difficult, but to see it as a mismatch. He's in pre contemplation, and if we treat him like he's in action, he's going to push back. Now, let's think about what motivational interviewing skills we could use to keep the conversation flowing rather than confrontational. This is where ORS comes in. We could use open questions to invite him to talk more about what drinking does for him. So you could say, "What do you enjoy most about drinking?" That shows curiosity instead of judgment. We can offer affirmations like, "Well, you've managed to keep your job and meet your responsibilities even while drinking. That really takes a lot of commitment on your end." That's going to build some rapport. And of course, reflections like, "Well, you're here to satisfy the court, but you don't feel like drinking itself is a problem." Reflections show that we're listening and not arguing. And finally, how would you invite James to consider his own reasons for change, even if abstinence isn't his goal right now? One way to do this is to focus on his values. He mentioned his partner nags him about his drinking. Instead of saying, "You need to stop for your relationship," you might reflect, "It sounds like your relationship is important to you, but drinking is causing tension." That invites him to consider what matters most to him without pushing abstinence. Another option is to ask about his goals. "Well, what would you like your life to look like once this court requirement is behind you?" That opens the door for him to explore possible reasons for change, whether that's reducing his drinking, avoiding legal trouble, or maybe something else entirely. And the bigger lesson here is that there isn't one right answer. Stages of change, exam placement, even the way that we read resistance, all of these can feel subjective. Our job is to be aware of our own bias, especially the urge to push people towards what we think they need, and instead stay grounded in curiosity, compassion, and alignment with where they really are. So when Miller and Rollnick talk about motivational interviewing as that flowing conversation, this is what they mean. Flow comes from attunement, listening closely enough to know when to reflect, when to affirm, when to summarize, and when to simply hold space. It comes from hearing the difference between sustained talk and change talk and knowing how to respond. And it comes from reframing resistance not as the enemy, but as a compass pointing us back towards alignment with the client. We have our last opportunity for a pause and reflect question right here. So I want to know what skills or counselor attitudes are most important to creating conversational flow. What do you think about that? What have you noticed? Maybe the opposite. What really doesn't help with conversational flow? And I'm also curious about your answers to how does this connect to the idea of empowering rather than controlling clients? Now, before we wrap it up, let's just step back and think about how all of these tools we've been talking about fit into something very practical: the initial assessment. When you sit down with a new client, especially one in the pre contemplation stage, your role isn't to lecture or confront, it's to create a space where information can flow. The assessment is your chance to begin gathering details about drug and alcohol history, patterns of use, medical concerns, the environment, and really work through those 6 dimensions of ASAM to help you collect a lot of really good information. But equally important, it's your chance to set the tone for the therapeutic relationship. So, how do these concepts come alive in assessment? When we're looking at power and agency, instead of framing questions as demands, invite the client's perspectives. So, for example, you could ask, "Can you tell me about what a typical day looks like for you and where substances fit in?" That approach respects their autonomy while still collecting the information you need. For stages of change, you want to listen for where they're at. If you hear sustained talk, that's not resistance, it's a clue that they might be in pre contemplation or contemplation. Adjust your responses to match their readiness rather than pushing them somewhere they're not. For harm reduction, keep in mind that even small changes matter. If a client says, "I don't want to stop drinking, but I've cut back on weekdays," that's really valuable information. Reflect and affirm it. It sounds like you found a way to reduce some of the risks. For MAT knowledge, you want to be prepared to ask if they've ever tried medication assisted treatment or if they've heard of options like buprenorphine, methadone, naltrexone. Even if they're not interested now, planting the seed might open a door later. And then we can use our OR skills. Use open questions, affirmations, reflections, and summaries throughout. This is how you gather details about onset, frequency, tolerance, or withdrawal without making it feel like an interrogation. And for ACM and SBIRT, remember your assessment is also about level of care. Think about what you're hearing in terms of ASAM's 6 dimensions: intoxication risk, medical issues, readiness, environment. And SBIRT reminds us that sometimes the most important work is short, respectful conversations that can nudge somebody towards thinking differently about their use. Taking together, these tools remind us that assessment isn't just about collecting data. It's about starting a relationship rooted in respect, curiosity, and empowerment. And the more that you practice weaving MI spirit into the structure of assessment, the more natural it will feel to balance both tasks at once, getting the information you need and honoring the person in front of you. So we've covered a lot today: power, definition, and flow. And you might notice different pieces landing for you in different ways. Maybe you found yourself nodding along, or maybe you felt some tension or some questions come up. All of that is part of the process. You don't need to have it all figured out right now. The work is just simply noticing what stood out for me, where did I feel resistance, where did I feel curious. These are starting points for growth. As we move forward in the coming weeks, you'll have more chances to explore these themes and experiment with how they show up in your practice. For now, I invite you to sit with what feels most alive for you after today's lecture. You showed up, you engaged, and you stretched into some of the biggest shifts happening in our field. And that's really meaningful. And I feel like you should just give yourself a pat on the back right now. I look forward to diving deeper with you next time. Thanks.